Okay, everyone. Well, again, thank you for the very kind invitation to come and speak. I do try and respond to all of the support groups that ask me to speak. Some of them don't ask me, or some of them ask me and they get told not to ask me, but I'm here and I'm delighted to be here. What I was going to do this morning is to talk through what I regard as probably the most important part of Parkinson's, because when we think about Parkinson's, everyone in this room knows it's not just slowness, stiffness, tremor. Effectively, there's a whole bunch of other things that cause probably much more in the way of quality of life problems. And so what I want to do is take you through those non-physical or non-motor symptoms and explain a little bit about how common they are and some really focusing more on the practical stuff. What can you do about them? Because one of the things I notice when I see patients, especially as a second opinion, is that people have got a whole bunch of problems and you say, well, what are you doing about that? And they go, oh, no one's ever mentioned it before, nothing to do. You know, I didn't know I couldn't do anything. And you kind of go, no, this is important. What I will do is I will mention some medications at times. And the fact of the matter is these are sort of personal preferences. Some of them have got very good evidence. Some of them are based on, if you like, experience. And so the fact of the matter is that your own specialist may do things completely differently, and that's perfectly fine. The key part is to be able to know that there are choices. And if you're prescribing medications like I do, you kind of go, I can live with the choices that I make. Okay. So let's get into it. So last night I was talking to, or yesterday I was talking to some healthcare workers about Parkinson's disease, where everyone I hope in the room knows that what's happening in your brain is that cells are dying. The cells make chemicals. When the chemicals go missing, you get your symptoms. And the predominant thing that people focus on with the tablets is treating the physical symptoms. And those physical symptoms arise because you're losing dopamine as the leading transmitter in the brain. So therefore, Parkinson's should be really easy to treat because you just lose dopamine and you replace dopamine. And when the going gets tough, you might find that people get that wearing off at the end of their tablet, and then they get the dyskinesias when they get too much on board. And you say, well, that's okay. We've got these other therapies, deep brain stimulation. We've got pump therapies, injections under the skin, tubes into the stomach. And you go, well, that should be easy. And Parkinson's, you know, very simple. It's a dopamine disease, but it's not that simple. And we know that it's a very expensive disease. Some of the latest reports suggest it might cost the Australian budget about $10 billion per year. Most of that's on healthcare and nursing homes and people leaving employment, and also caregivers having to leave their employment to make allowances to be carers. And as well as the financial cost, essentially there's a societal cost, and we lose good people from our society, as it were, and we have institutional care. And as well as these problems, it's basically about quality of life. So eventually you lose good years of life from your day. And you do that not only because of the physical symptoms that we can treat relatively well, and we can treat them relatively well, compared to when we didn't have those tablets. So if you got your Parkinson's in, say, the 1940s, 1950s, when we didn't have Parkinson medications, the average life expectancy for someone who was diagnosed at, say, 65 would have been 6 years. The average life expectancy if you're diagnosed at 65 now is pretty much your natural life expectancy. So the average life expectancy for male Australians would be late 70s, ladies, it'd be at late 80s. And you get that with Parkinson's disease. Your quality of life is impacted, but the Parkinson's medications have basically made this disease so that you can live with. And, you know, people say to me, this is a life sentence, not a death sentence, okay? So I think it's really important to realize the tablets are great, but what can we do that make things better? And I want to start in the engine room. Constipation. It is said that about 98% of patients with Parkinson's disease will get constipation, and there are various causes. So the commonest thinking of this is that patients don't move around a lot, and that makes your bowels sluggish. But actually, probably more importantly, we know that the nervous system not only affects the cells in the brain, but also the nerves that go to the gut. The nerves that go to the gut tell the gut to move things along. So when those nerves are affected, what you find is that things aren't moving along. If there's a slow transit, what happens then is the gut says, oh, it's moving very slowly. Let's get all that water back. So basically, then you go from having a nice soft, you know, if you like, juicy stool to having a dry pellet, which then basically becomes harder to pass. So in actual fact, constipation is really common. It's part of the disease. And we have a number of approaches that we have towards treating this. The top approach people would use is diet. So adding fiber to your diet. So the prunes, the bran cereals, etc. But none of these things work, and even the medications I'm going to talk to you about work unless you're taking in lots of fluid, because you've still got a slow gut. And if the gut is going, if the drugs are going to work by, if you like, softening things, what they do is they draw fluid back. And if things are, if you haven't taken enough fluids in, you can't draw fluids back. And if you end up doing that, you end up with a low blood pressure. We'll talk about that a bit later on. The catch is, and we'll talk about it next, is that the bladder is also affected in Parkinson's. So here you are saying, doctor, I've got constipation. Oh, that's fine. Just double the amount you're drinking. Doctor, I've got urinary frequency and urgency and I don't make it to the toilet, and you've just made my problem worse. So we have to balance these things up, but we balance them, we must. So in terms of other things that we think are simple approaches, exercise. I just told you that not moving around makes your bowels sluggish. There's definitely good evidence for that. And there's definitely good evidence for exercise across lots of things. We can talk about them more at length, but, mood, cognition, and obviously the physical side of things, but also your bowels. Okay. So, and just bear in mind the fact that if you get constipated with Parkinson's and your memory and your thinking is a bit off, your chances of going into hospital with a delirium are very high. So you need to keep the bowels moving. Ideally, we need to train the bowels, so routine habits. So even if you don't think you need to go, a bit like when we do toilet training for children, I am going to go at these set times and effectively try and establish a bowel habit, okay? And do not ignore the urge. With the bladder, it's really hard because it's kind of embarrassing, but sometimes with patients, they'll say, well, I'm just going to put it off because it's a lot of hassle going to it. I'll just see how it, that's a bad thing. If you get the urge, go try and empty your bowels, okay? How about the treatments? Now, I love this picture because essentially it reminds me of the old advert that Hoover vacuum cleaners used to put out, it beats as it sweeps, as it wipes, as it cleans. It's you have to do all of these things. And so the first the things that we want to talk about is how these drugs work. So there are bulking agents that add bulk so that your stool is bulkier, softeners and lubricants, osmotics, which basically draw fluid in, and stimulants, which basically trigger your bowel to contract. And they're all different, and you can use them all in combination to do different things to help your bowels moving. The trick is not to get behind the curve. You need to keep your bowels moving, not wait to be constipated, then solve the problem. Then it all becomes awful because you get overflow diarrhea, and then you think, oh, I must have diarrhea, I'm not constipated anymore. And actually what's happened is you've got this bunch of rocks that are sitting there and then just fluid coming over the top. So you need to get ahead of the curve. So the bulking agents basically are husky things, so fibers, so psyllium husk, benepil, and chicory root. They draw fluid in because of the structure of the fiber. If you think about a woolen jumper and you put it into a sink, it'll soak up all that water because of the structure of the fiber. This essentially is the same thing. So you need fluids for these bulking agents to work. It is a maintenance treatment. So if you are constipated already, starting this isn't going to save you. You're already constipated. You need to do this ahead of the curve. It takes about 2 to 3 days before these things start working. What about the softeners and the lubricants? So this is things like Coloxal. Again, these draw fluid and fat back into the stool, okay? So effectively, they work by making things softer and slippier. Again, they're maintenance and they take a couple of days to work. So you can see that you can't save yourself. You need to be taking these things ahead of the curve. And it depends on who you're talking to. I've got some patients who will take 2 Coloxal a day and they're perfect. I've got others who will take 2 Coloxal 3 times a day, lots of 20 mils of lactulose twice a day, 2 sachets of Modafinil twice a day, and they're still troubled. Okay, so everyone's a bit different, but you need to titrate on your own bowel actions. Again, needs fluids, can't do without it. Osmotics, so this is things like the Modafinil, the Normacol, lactulose, and again, these work by bringing fluid back in and basically allowing you to have a softer stool. And then there are things like the glycerol suppository. So effectively you can pop these in yourself, and this will work as a rescue measure. So effectively this is something that will work hopefully within that hour. So if you're struggling and you need to get going, you get this in, but you need to use those other things regularly to keep the bowels moving. So we really just need to, if you like, avoid getting into that situation of cramping where the bowel is uncomfortable. So lots of fluids and lots of these things early. And then what about stimulants? So things like senna is a stimulant, usually combined with cloxol and senna, and they take less time, so they take about 3 to 6 hours. And then, of course, if you want to go to war, there are things like the phosphate enemas. Again, these are a bit more troublesome. This is a bit like a firework, light the blue touch paper and retreat to a safe distance. And essentially, you need to have a good team around you, especially if you've got a frail patient, really for severe constipation when people are in trouble. So those are all the, if you like, my mother told me these things would be good. But interestingly, even constipation is now getting to go in the world of research. And there were 2 studies, both came out from Kuala Lumpur in Malaysia, both independent. I don't know how bad the problems with constipation are in Malaysia. When I went to Malaysia, trust me, I didn't get constipated. But these 2 centers both did trials looking at probiotics. And what they actually did was they saw patients with Parkinson's disease who complained of constipation, that is less than 3 spontaneous bowel actions per week for at least the last 3 months. And they treated them with probiotics, so multi-strain probiotics. So you can buy these from your friendly chemist. It doesn't matter which particular bacteria in there, just go and get the multi-strain ones. And what they did was for 4 weeks, they treated these patients. And basically, you'll see that the number of bowel actions in red went up. With the probiotics, when they were given a placebo, not a real probiotic, the bowel didn't wake up. So the bottom line is that this change in stool habit is real, and this is something that you can do yourselves. So I used to think, is there any evidence for this? The great thing about medicine is that people should be looking for evidence, and if it's real, we'll have it. It's there, it works. So in actual fact, this isn't a rip-off. You can actually go out and get probiotics for yourself if you're worried about your bowels. It should help your bowel habit. Okay, we're going to move from bowels to bladders. Basically, constipation can happen before you get the disease, but bad bladders tend to happen as your disease progresses. So in actual fact, your bladder function seems to get worse as your disease advances. And you get urinary frequency, so particularly at night, having to get up many times. Urinary urgency, where you actually don't have time to get there. I need to get there in a hurry. Hesitation is where you think, I'm there, oh, nothing's happening. And that's a bit more of a concern, especially for the boys who might have a big prostate. And then there's stress incontinence. So this is, I sneezed, I wet myself. And this is usually the girls, and it's usually due to childbirth and having prolapse. So these things are all made worse by Parkinson's. So if you've got a big prostate or you've got a prolapse and you've got Parkinson's, it's a worse scenario. Now, I know, I don't want to bore you, I know you know the neuroanatomy of the way that urine loss is controlled. And I won't bore you with this because, I'm completely sure that you're across it. But there are 2 things that you need to know. Your bladder essentially is a muscular bag with a valve at the bottom. In Parkinson's, the muscle activity goes down, so you get a slack sphincter, and the bag, the muscular activity goes up. So you get an overactive bag and a valve that that leaks. So you got a bad combination because of the disease. So in actual fact, in terms of our treatment strategies, what we need to do is think about how do we make the bag less active and the sphincter better, stronger. So the girls in the room are already aware of this because they were told after they had children, do pelvic floor exercise. I can see some of them doing them now. Gently lifting in their seats and gently coming down. If you want to Google it, the word is Kegels, K-E-G-L-E-S. And this is, concentrating and focusing on those muscles and the boys, you can do this too. And of course, for the boys, what the guys from urology will have told you is practice stopping and starting your stream by contracting. So you actually build up that muscle at the bottom. In terms of our practice, urological review. So I pick up about 1 prostate cancer in my Parkinson's population a year because I send all of these boys to see actually all the boys and the girls to see the urologist. And I've got 1 prostate cancer about every year. So you can't ignore it. One of the rules about Parkinson's is don't blame Parkinson's for everything. The other thing with that, of course, is the boys get prostates, the girls get prolapse. So in actual fact, you need to do the magic bucket test. Is your bladder emptying? Is it emptying fully? Does it leave a residual? Is there a problem that could be fixed with surgery or, some other process? So, if you've got a big prostate, you might need to have a rebore, one of those TURPs, a TURP. For a girl, of course, you might need a hitch, as it were, a tightening operation. Rehabilitation to pelvic floor exercise, and then medications. And I'm going to go through the medications relatively briefly, but to flag that they exist. The classic drugs to use in people with overactive bladder are called the anticholinergics. And these are things like oxybutynin and tolterodone. And what they do is they block the acetylcholine part of the nervous system. And that's the bit that deals with the bladder. The trouble is, it's the same bit of your nervous system that does thinking. So all of these drugs have an impact on cognition. So in actual fact, I say avoid these medications because they can trigger poor memory. They can also trigger hallucinations in those people who are susceptible, and they will give you things like blurred vision and a dry mouth. So I'm not overly keen on anticholinergics, despite the fact that they suppress this overactivity of the bladder muscle. Other medications, tricyclic antidepressants. So these are drugs that were designed for mood, but they actually, again, act on the cholinergic system and also the alpha-adrenergic system. And they, again, have the same side effects. They'll give you poor memory, hallucinations, dry mouth, blurred vision. I don't tell you, I've used these drugs in Parkinson's patients, but you have to be very careful that you're not going to make something else worse and very low doses. This guy is a newish guy on the block, mirabegron or betmegra. It works in a slightly different way, targeting the nerves to the bladder. And as far as I can see, it seems to be well tolerated in patients, even with dementia. This drug is not yet licensed on the PBS, so it's a bit more expensive. And what I say to patients is, try it. Try it, you might like it, but try it. The fact of the matter is it comes in 2 doses. The first dose is 25, the second is 50. You do 1 month at 25. If it's crap, you go to 50. If it's crap, you stop. So you'll spend 2 months' money, and effectively, if it works, it'll be fantastic and it'll be money well spent. And if it doesn't, then you'll just give it away. The fact of the matter is that in, say, 5 patients, I'll get 1 that said it made the bladder worse. I'll get 2 that said it made no difference. 1 that said, I think it's better, and 1 that said it's amazing. So generally, it's worth a try from what I've seen in clinical practice. Not a published study, clinical practice. Antidiuretic hormone, I don't think anyone really uses it. This is a drug called DDAVP or desmopressin, and basically it tells your kidneys to retain fluid. I don't think I've got any patients who are taking this at the moment, but it exists. Far more commonly is the idea of basically getting rid of your crow's feet in your bladder. So you're familiar with the idea of the actresses and the actors having Botox injections in their face to get rid of the wrinkles. Your muscle in the bladder can also have Botox. So the urologist would use a camera to look into the bladder and then pepper the bladder with Botox. And basically that makes the muscle paralyzed, and it means that the bladder can get fuller before it starts contracting. If you overdose the bladder won't work, and you'll need a catheter until the Botox wears off, which might take 3 months. But what typically happens is that the urologist doing it will underdose the first time, and the patient may say, it worked really well for a month, and then it was useless. The fact of the matter is, once you get the dose right, you can generally get about 9 months out of each injection. And if you think about how many times you're up at night, if you could bring that down so you can get the night through, or just up once at night, it's worth a go. So in actual fact, I think Botox is really good because it doesn't have the side effects of hallucinations, confusion. It does involve a small procedure, and it's not for every patient, but it's certainly one that I like to explore in patients who are getting a lot of disturbance from their bladder. More evidence. So that, again, it's been a year for the bladder and the bowels. And this is actually a study from my mate David Byrne in Newcastle. And basically, this is a study looking at bladder training exercises. So this is about doing that squash and hale, and also about distraction and voiding schedules, and how to avoid the urge to pee. And basically, it's a 12-week training program. It's not available everywhere, but what the proof of principle says is if you can train people's bladder, you absolutely get an improvement in the number of times they need to go to the loo, and they feel as though there's less impact on their daily lives. So bladder training, very, very helpful, no side effects, and actually a sustained benefit in this study beyond the time that you are training people with their bladder. So if you can train people how to use their bladder properly, then in actual fact, this can be a very useful and non-drug approach, no side effects. Okay, we're going to move from the bladder to fainting. So fainting is common, and again goes with the duration of the disease. I mentioned to some doctors last night we lectured to, if you see fainting in the first few months of a Parkinson's patient, you have to worry that the disease is not actually Parkinson's, it's a mimic of Parkinson's. But Parkinson's disease, people with low blood pressure is something we see all the time, especially as the disease progresses, and especially if they're older. And what we need to do is think about the Parkinson drugs that they're on, but also the other drugs that they're on. Because the chances of a Parkinson patient being on a blood pressure pill is quite high, because blood pressure is common. But the chances of being on something else that might lower their blood pressure is quite high. So we have to review all the medications and see whether we need to drop off your 3 blood pressure pills that you now don't need because Parkinson's lowers your blood pressure, and all the Parkinson's treatments lower your blood pressure. So in actual fact, very important. Maintaining hydration. We talked about hydration in the context of constipation earlier. So keeping your circulating volume up, because you need it for your blood pressure, will require you to take fluids in. And you can think about isotonic fluids and all of those sorts of things. Most of you are sitting down, which is great, because you're about to hear a doctor say something you never hear doctors say. You can increase the amount of salt in your diet, because the salt will essentially make your blood more salty. Your kidneys will think, hang on, we need to retain water. You retain the water, your circulating volume goes up and your blood pressure goes up. The problem with this approach, of course, is if your blood pressure goes too high, you get hypertension, and the cardiac doctors say, which neurologist told you to have more salt? So you have to balance these things out. One of the other simple tricks is to sleep with the head of the bed raised. Now, this is important. People get this wrong all the time, and they put their feet up. And that's okay, because it'll give you, some blood supply, but you're lying down anyway. What you need to do is actually sleep with the head up about 30 centimeters off the ground. It's like being in the worst business class flight ever, because you think, well, I'm lying flat, but I feel funny. But this strategy is something that actually regulates or changes the way that your blood pressure reacts to posture, and allows you to have less in the way of fainting the next day. So you raise the end of the bed. In Australia, it's tricky to wear compression stockings, but those anti-DVT stockings can also help get the circulating volume back up to your brain, so you faint less. Very difficult when it's hot and sticky in Australia. I haven't seen a fishnet variety for those of you that are tempted, but certainly these are things that we can consider. In terms of medications, we've got a bunch of tablets. So fludrocortisone is a tablet that tells your kidney retain more salt. And just like the salt in the diet, will then allow more fluid to be retained. The problem with this strategy is your blood pressure goes up all the time, which means that when you lie down, your blood pressure goes too high. So when you're standing up, it's not too bad, but when you lie down, you might have it too high. The drug I tend to use, again, this is all off license, is a drug called Rivastigmine, and it's supposed to only work when people stand up. So the reason I use it is because you don't tend to get high blood pressure when you lie down. It's a drug you do end up having to take multiple times a day, 3 or 4 times a day. The dose can be altered. Side effect profile might give a bit of diarrhea, but most of the time well tolerated. The other medication that is out there is a drug called midodrine. It's now easier to prescribe this. It's a drug that works through a different neurotransmitter system, but again, it puts your blood pressure up. And so you have to avoid taking it when you're about to lie down. So if you're going to be up for a few hours, that's fine, but you can't take it just before you go to bed. So in actual fact, it's a drug that we use not very often, to be honest. And then there's a drug that isn't licensed here in Australia called droxidopa. It's been licensed in Japan for about 20 years. The chance of it coming to Australia, I think, is low. And I think the reason for that is because it probably doesn't do a huge amount. So it's one of those drugs that we're not really missing. I want to move next to drooling and saliva. So to drool or to dry, that is the question. And we actually have this problem all the time with patients. Sometimes they haven't read the textbooks. So the fact of the matter is Parkinson's disease usually causes too much saliva. So that's because you produce too much from the salivary glands and you swallow too little. So you get both of those things. But patients do complain of having a dry mouth. And if they do, first thing you've got to think about is this really Parkinson's? Is it some of their other medications? I mentioned some medications to give you a dry mouth. Is it the fact that they've got other diseases? So in actual fact, there are some diseases that give you a dry mouth. And that's important because some of them are things like cancer, and you have to screen for that very carefully. In terms of treating a dry mouth, basically you say, look, just take more fluids. That's the first thing to do. And people say, oh, did you not hear about the fact that I've got this bladder problem? And I say, okay, well, the alternative is that you can use some artificial saliva. Now, I don't know where they get artificial saliva. I don't know if they go to the Parkinson's patients who've got too much saliva and they bottle it and then recycle it. But by the time I've explained about artificial saliva, most people have said, oh, look, I think I'll just drink more. And I think that's perfectly reasonable. Drooling essentially is a big problem in Parkinson's disease. The first thing to do is to try and stimulate the swallowing. So lemon bonbons for the non-diabetics, chewing gum, sugar-free things that stimulate your swallowing, so chewing gum. And then probably the easiest thing to use is an Atrovent inhaler. So for those people who have seen people with bronchitis or emphysema, they'll get a gray inhaler from their doctor, and they're supposed to inhale it onto their lungs. Interestingly, what they say is, doctor, I get a dry mouth. And the reason they get a dry mouth is because their technique is crap, and they end up spraying the back of their mouth. And the reason that's useful for us is because we want to do that. So we use the Atrovent inhaler and say, don't inhale it for your lungs, just use it like a mouth spray. Hit all the salivary glands and see if you can stop the secretions. And you can use it multiple times a day. Not as hard as using atropine eye drops, which you can use. We have to duck the head back, and that's a bit harder. The other thing you can do is, again, use Botox, injecting the salivary glands this time, rather than paralyzing the bladder, paralyzing the salivary glands, and stopping them from secreting. The problem with doing that is the risk that you might make someone too dry or too weak. So their swallowing gets weak, and they might even need a feeding tube, and they can't support their head. So it's a very important thing we need to be careful about doing. Not many patients are having Botox with their saliva. But there is good evidence for it. And there is another drug that you have to inject. It's intramuscularly, not so easy here in Australia. But I think the simple things are better. What about bulbar problems? So swallowing difficulties, speech therapy early. It's very clear to me that patients leave things too late. They say, my speech is fine. You go, I need you to have speech that's fine in your late 70s, going into your 80s. So you have to practice now. You have to get your reserve up. So it's no good when people say, oh, I saw the speech therapist, and the speech therapist said my speech was okay. They may have said that, but they probably, what you missed was they said, but you still have to go and exercise. Okay, it's the same as the physiotherapy. And I won't steal Ryan's thunder, but guys, you need to be doing this from the get-go as soon as you're diagnosed, because you cannot get your speech back. You cannot get your balance back. And I've got no drugs that help. So it's all on the therapists, the physios and the speech therapists. But you're up for the challenge, aren't you, Ryan? Definitely fantastic. So soft speech can be improved by speech therapy, and it's very important. It doesn't really matter what you do, but what you don't want to be is essentially that person wearing a Kylie Minogue microphone trying to be heard, walking around with a personal speaker, which is fine, but geez, try and save your own voice, okay? And speech therapy is the only way to go. So I'm going to shift now into what we call neuropsychiatry. So this is a combination of the things that you might think are psychiatric disorders or cognitive disorders. And we'll go through these. And we're going to start with one that gets all the headlines, gambling, impulse control disorder. So spending too much money, dressing up in women's clothing, which is fine for women, but not so good for the blokes. And effectively, we know about this literature now. We didn't know about it when we started using some of these drugs for Parkinson's that could trigger these behaviors called impulse control disorders. So gambling, hypersexuality, paraphilias, so sleeping with things that aren't real or the wrong sort of people, compulsive buying, so shopping online, remortgaging the home, all of those things to do these, binge eating, so raiding the fridge at 4 o'clock in the morning and just having the sugary things. And it's not uncommon. So about 14% of patients will have some degree of this. Some of the patients will have more than one of these behaviors. Not most of them are not problematic, but I've seen the patient who ended up basically remortgaging the house because he needed. Look, the wife was upset when she found out about prostitutes. She was really upset when a transsexual ladyboy turned up at the front door of a house that was remortgaged. So when it goes badly wrong, it goes really badly wrong. And we know it seems to be to do with the drug. So the drug that does this most is the dopamine agonist. So in our world, pramipexole or Cifrol is the one that's the most likely to trigger this behavior. So about 14% of patients who are on that class of drug will get this problem. On levodopa alone, it's about 7%. And razagiline, sapinamide don't seem to cause this. And if you combine the drugs, it only goes up to about 17%. So most of the risk is in those dopamine agonists. So if we prescribe that drug, we really want to make sure that people haven't got risk factors. Are they single young males who don't have a woman who's going to keep them on track? You marry for a reason, guys. It's very important. They keep you out of a nursing home. They keep you out of a lap dancing club. And you need to know who is at risk. And basically, in this audience, it's usually the younger males who don't have support networks. When I do this talk in Sydney, in central Sydney, it's the Asian gambling population. Male, female, they are just big gamblers. It's a cultural thing. Australians are big gamblers. The rates of problem gambling here are double what it is in the rest of the world. So all of us in Australia seem to be prone to this. The Asians I have to be even more careful with. They just seem to be much bigger gamblers. And there are genetic risks for this. And I've talked about these things here. So if they've got a history of gambling, or if you've been an alcoholic kind of dependent sort of personality, you have to be careful. And we really try and get rid of that offending drug. The dopamine dysregulation syndrome is rare, but essentially this is where people get high on their drugs. So I've only had about one of these in the last 10 years where the guy was basically stashing his drugs and then just overdosing with them because he liked the high, the feeling he got from them. And people end up doing things where you can't tear them away from their activities. So they just end up ignoring food, ignoring requests for other things. And it's like an addiction, really. So it has to be dealt with like an addiction, trying to wean things down, a lot of counseling, a lot of support, but very rare. Not rare, on the other hand, is mood disorder. So depression and anxiety in Parkinson's, about 40% of patients will have some degree of it. And it's not a reaction to the physical disability. This doesn't correlate well with the physical signs of Parkinson's disease. It can even happen before you get your physical diagnosis. So it's the chemicals that are going wrong in your brain that seem to be driving this. And the profile of depression in Parkinson's is different. The suicide rates in Parkinson's are really low, which, you think about it, with such a terrible disease in so many ways impacting on your life, that the suicide rate is terribly low. And the reason is because people aren't profoundly sad. They're just pissed off. They can't concentrate. They just feel as though they're not the same person. And the first line thing is counseling. So no medication, get counseling. Very much better, I think, if you can find someone you can relate to and get on with. But we need somebody good. And it seems to work well for things like anxiety or depression when there isn't an obvious other driver. So the classic situation is you look at a patient and they say, yes, I'm looking after my mother who's got dementia and my son who's got autism. And you go, no amount of counseling or medications is going to make all of this better. So it's about supporting and saying, well, how can we go with this? And as you know, Parkinson's New South Wales do offer counseling. It's can be done on the telephone. And there are centres who can do this. In terms of the treatment, we treat it pretty much like all the standard depression and anxiety. There are some caveats about which drugs we give to which patients, but it's important for us to understand that. One of the things that we do look for quickly, though, is the idea of whether this is related to your Parkinson drugs wearing off. So we have a phenomenon when the tablets wear out, where patients' physical symptoms come back, but also they can get what we call a psychic off, where their mood gets much worse or much more anxious during the time their tablets aren't working well. So if you find that history, you're not looking at antidepressants, you're looking at making the Parkinson's disease better controlled. This is a patient of mine who kindly agreed to share her video.
Oh, the mood very bad. Can't smiling, can't talking.
And you feel the breathing change?
Yeah.
What happens?
I feel very, very hard. Not feel well.
The mood is bad, it's anxious, can you breathe?
Breathe can, but very hard.
Tight?
Yeah, tight.
Tight. And do you feel depressed? You showed me that word earlier, what is it?
Yeah.
And then you take your tablets and it goes away?
Go away.
Goes away.
Yeah.
But sometimes just takes at least 40 minutes
before it all gets better.
To get to normal.
So it's a beautiful story. It takes about 40 minutes for the levodopa to get to your brain. She gets all these feelings. That Chinese sketch is quite funny because I couldn't work out what she was saying. So I said, write it in Chinese. I love technology. So I scanned those characters and up came the word depression. It's just beautiful. And she couldn't articulate it in English. So you have to sometimes use the tech in your favor. But this isn't only an Asian problem, of course. Bottom line is this affects lots of patients. How do we treat it? We use the standard antidepressants that are there. The trials that have been done are pretty mixed in terms of, what they come out with as to which drug is best. And you have to sort of pick it on what side effects you think you're going to get in particular patients and whether those side effects might be good or bad. So if somebody's, potentially got a lot of early problems getting to sleep, you think, well, maybe a tablet that helps with sleep and deals with anxiety might be best. One of the things I just wanted to flag, though, more data. Again, it's been a great year for trials in non-motor stuff. This is a trial that was published basically looking at telephone counseling. And so basically telephone counseling versus treatment as usual. And they used master's level therapists. So they don't have to be very extremely qualified or experienced counselors, but they had a very manual driven book that they followed to help with these patients. And it talked about cognitive restructuring, how you manage anxiety, how you deal with your sleep patterns. And basically, it worked. So all these patients who had Parkinson's disease with depression had the counseling, and what they showed was after 6 months, their mood was better. And this is not a drug intervention, this is counseling. Now, I know that this is in the context of a research program, and maybe it's super selective or not, but counseling is effective. Don't ignore trying to talk to somebody. Okay, let's talk about sleep. Sleep problems are bad, and they're almost ubiquitous. So insomnia, trouble getting to sleep, staying asleep, getting back to sleep. Daytime somnolence. I take it as a badge of honor these days when I'm looking at a support group and half of you are asleep. And I go, yes, I was talking just about that now. It's really important. Wake up. And then this other thing called REM sleep behavior disorder. How many people have heard of REM sleep behavior disorder? Excellent. A few of you. It's quite funny. When I first started talking about this 10 years ago, nobody had heard about it. And then I asked the next question, how many of you have been punched or punched out in your sleep? How many of you have been punched? Yes, yes, yes. Fallen out of bed? Yes, yes, yes. So that's what we're talking about. And this is what it looks like. This is a video from the Mayo Sleep Clinic, which basically this patient is asleep. He's in dream sleep. During dream sleep, your brain is very active. Your body should be completely relaxed. It should be atonic, not moving. If you're lying next to this guy, you're about to have a rude awakening. About a third of these patients will injure themselves or their bed partner. So it's really important, and it's very specific. So basically, when they look at the series that have been done with this, over 90% of the patients who do this, who don't have another explanation, will have Parkinson's disease or dementia with Lewy bodies. So it's very specific. And the other thing that's interesting is this predates Parkinson's very often. So about probably a third or a half of patients will start doing this when they're perfectly well in all other regards. And then 5, 10, 15, 20 years later, will develop Parkinson's. So if we had to target a population where we thought a disease-modifying therapy would be most effective, it's these guys. And watch this space, I'm working on that problem. How do we treat this dream behavior? The answer is badly. We had 2 drugs. One was called Clozapine. My friend in Korea, in Seoul, BJ, Byung-Suk John there, did a trial seeing how well Clozapine worked for dream behavior. The answer is it didn't. So that was a drug that we thought might be useful. Actually, the data doesn't suggest that it is useful, although we'd still prescribe it for individual patients because we think, well, it sort of helps with some of these things, surely. And the other drug we used to prescribe all the time was melatonin. So I did the trial for melatonin, showed no benefit at all for this dream behavior. So at the moment, it's really hard to say what we should do about people acting out their dreams, other than get a bigger bed. Make sure the bed environment is safe. So there are no things that are breakable around you that you can land on. Glass being a classic. Make sure that if you're sleeping with your partner, have a pillow that you can use as a bolster. Do not wake them up. When they're kicking off, do not attempt to wake them up because they are in their dream. They will fight with you next and they won't remember, they don't know it. Ladies, I have come across one situation where a guy was screaming out a woman's name. It was his first wife's name and they weren't fighting. Let's just put it that way. And you have to wear that. Unfortunately, he had no recollection of it whatsoever. On top of that, you need to avoid alcohol late at night. So certainly no alcohol beyond 8 o'clock, and avoid violent content. So guys, rugby league is violent. And they usually have 2 games on a Friday night and one of them is later than the other. Do not watch the rugby league or videos or movies late at night because you'll let the number of these patients who do that. I was just tackling a guy. I was just kicking the ball. Yeah, not good. Okay. What about getting to sleep? Well, actually, again, more evidence this year, again, published this year, last year, in fact, exercise for sleep. So absolutely no doubt that if you exercise intensely 3 times a week, you will improve your sleep, not only subjectively, but your actual sleep efficiency in the sleep laboratory. So there is no doubt that exercise is really good for everything. We don't know. And we have no evidence to suggest it will slow your disease, but there are so many other reasons that you should be exercising and exercising hard. So in terms of managing sleep, sleep hygiene is really important. Those guys that want to have a nap during the day, that's fine, but you do not go to bed for 4 hours in the day. That is not a nap. That is a sleep. So nap's going to be limited to 30 minutes. You have to go to bed at regular times. If you are there playing on your iPad at 11 o'clock at night, it is not a good way of putting your brain to sleep. Okay, if you wake up in the middle of the night, oh, I can't sleep. I know what I'll do. I'll go and put my iPad on. I'll start Googling, whatever. Fact of the matter is not going to be conducive to sleep. Hot baths, vigorous exercise, caffeine late in the evening, basically avoid these things, okay? Because they will basically wake your body up. If you can't sleep, do get up, but don't turn the lights on. Low light situations, some stretching, some gentle music. My grandmother, my Welsh grandmother, always said, a warm milky drink. I have not seen a randomized control trial that says that she's wrong. So I'm still advocating for warm milky drinks if you can't get to sleep at night. We have to, from our side, assess for physical changes like, is my Parkinson's disease undertreated overnight? I can't roll over, I'm uncomfortable, I get cramp in my foot. That's something we need to do. And then non-drug approaches, so relaxation techniques, massage, stretching, exercises, all very important. What about the guys that are sleepy during the day? Very bad symptom to have, often associated with worse prognosis. And really what we want to do again is exercise. Exercise will wake you up. It'll stimulate the adrenaline. It'll get you going a bit more. So regular exercise is good. Medications, we don't really have any. There's a psychostimulant we use for a condition called narcolepsy called Modafinil. It's been trialed a few times, and basically each of the trials doesn't show it's very effective. If you combine the data from the trials, maybe it works a bit. In the patients I've tried it in, it's been a bit of a flop. Similarly, we used to think caffeine would wake people up. The trial has been done. It doesn't seem to keep patients awake with Parkinson's disease. And so I don't know that we can necessarily advocate using caffeine to keep you awake. So we're going to move from sleep into cognitive decline. So cognitive decline, of course, is one of the frightening parts of Parkinson's. And it's interesting and important to know that when people first present to see the doctor and get their diagnosis, a large proportion of them already are showing signs of cognitive impairment, not demented, but on their way. And often in a pattern where they're struggling with things like working things out, planning, judging distance, judging space. So this is often driving. Think about concentration, changing your mind, drifting in the road with visuospatial. So driving and Parkinson's is a very important thing. At any time, about 20% of Parkinson's patients would be satisfying criteria for dementia. And we know that the longer you have the disease, the more likely you are to have dementia. But it doesn't work that you say, oh, I've had 20 years of disease, therefore my risk of Parkinson's is 80%. It doesn't work that way. What it is that basically, so if you're diagnosed at 40, the chance of you being demented at 60 is pretty much zero. In fact, we published that paper. So essentially, it depends how old you are when you get your Parkinson's. So if you're in your 70s, the chance of you dementing is going to be higher because there's less reserve already in the system. If you're in your 50s, you'll go probably into your late 70s before you start seeing these bigger problems. In terms of what we do for it, cognitive training. So we were the first group to actually publish that cognitive training can be beneficial. And we tried to get this program funded by the New South Wales state government. You want to know. So basically what we now do is to say, look, go online, do things like lumosity.com or Brain HQ, and you can do these. These are really useful because they actually test the domains of your cognition. So is my memory bad? Is my visuospatial bad? And they'll tell you what you're bad at. They'll track it, and they'll also give you those exercises to do that will make that thing the priority. So you tend to work on the things you're bad at. In terms of the really demented patient, that is to say this person, is really struggling, we look and say, okay, what else is aggravating this? Is there a mood disorder? Is there poor sleep? Are there any medications that we should stop? And then are there any medications we can use? And there is a drug that we stole from the Alzheimer's world called Exelon or Rivastigmine, either in a tablet or a capsule or a patch. And basically this seems to help a bit, but it takes people from being demented to being a little bit less demented. It doesn't make you normal. And certainly if you give it to people with mild impairment, it doesn't make them normal either. Otherwise, we'd all take these memory boosting drugs. I mentioned some of those already. There is this, and it hasn't been published yet, and I don't want to raise too much expectation, but there is a drug trial that happened and we were part of it, mainly in Spain, but in Australia we had a few sites, of a new drug. And effectively, the company has announced that they thought it was a positive study for cognition in Parkinson's dementia. What they haven't done yet is publish it, and it may be that it's taking a long time to get it published, but we're hoping to see whether that will be something that we could then start using in clinical practice. Not available yet. So we're going to move from cognition. I think we're going to go finally into psychosis. So psychosis breaks into two things-ish, three. So hallucinations, I see something that isn't even there. Misperception, I see something that is there, but I misinterpret what it is. So I think this is a snake. And finally, delusions. I believe things that aren't true. My wife isn't who she says she is. She's an imposter pretending to be my wife. People are trying to break into my house. They're stealing my things. I'm being poisoned. It's a very limited repertoire, the delusions repertoire, and it can be very difficult for people to manage at home. And it's common, especially with advancing disease. And there seems to be a spectrum, sort of, benign through to more psychotic. If it is unexpected and suddenly someone becomes agitated and aggressive, you've got to rule out the cause. Have they got an infection? Usually a urinary tract infection for the boys and girls. Have they got a metabolic? So has someone given them a new tablet? Has something changed? And then change those circumstances, manage them, if you like, to make sure they're safe. If it's expected, that is to say, you've got someone with 20 years of Parkinson's disease and they're starting to get these hallucinations, they're not bad, then they get more delusion, then they get worse, then we try and simplify their medications and try and get down to the least amount of drug to keep the patient mobile. And there's this debate between sane and slow versus mad and mobile. And there's a divide between patients who quite like the idea of being mobile, and there's obviously the caregiver who tends to like the patient being sane. So I think this is a balance we have to strike. If it isn't controllable, we've got some tablets. They are effective. The most effective drug, the only one with any good evidence, is a drug called Clozapine. The problem with Clozapine is it can rarely cause a reaction where you lose your white blood cells and you're prone to infections. So Clozapine is only prescribed in very specialist clinics. I always joke that you have to be the firstborn son of the Pope and left-handed and Aquarius before you can prescribe it. It's that complicated. There are other drugs which don't have as good a set of evidence, but we use them all the time. And what we try and do is use them in low doses for the minimum amount of time, because we do know these drugs are associated with a slightly increased risk of cardiovascular death. But the question that we always ask in the clinic is, your husband or wife is at home, they're psychotic, they're sleeping with a knife under their pillow. This tablet might increase the risk of them getting a heart attack, or they could just stab you in the meantime or go into a nursing home. What should we do? So it's a conversation where you have to weigh up the pros and the cons. The medication we use for memory can also improve some of the hallucinations. So some of the excellent use is there. And there is a new drug that is not, it's not that new now, it's about 5 or 6 years old, in fact, only available in the States, hasn't really caught on in the States, maybe it's just too expensive, which works in a slightly different way to most of the drugs that we have, called pimavanserin. And it does seem to improve psychosis in Parkinson's, but we haven't been able to persuade anyone to give us the drug yet here in Australia to see if it works. So I think that was my last slide. I will remind you about the Dash to the Infoloan booklet, which I wrote many years ago now for Parkinson's New South Wales, which talks about a number of these features, depression, anxiety. You can get this online. You can get it from Parkinson's New South Wales if they're still printing it. And if you don't, you can hopefully ask them for a copy. So just in summary, there are lots of non-physical symptoms in Parkinson's, and I think they're more burdensome than the motor symptoms. They often coexist. And of course, people with bad Parkinson's have got bad physical and a lot of these non-motor. So it's very common that you see them together. One drug doesn't do everything. Treating one thing often will make another thing worse. So you say, I'm treating your anxiety, and the drug I gave you just gave you hallucinations. That wasn't a win. Okay, we'll try another approach. So it is a bit suck it and see. And I often find with patients that they'll come back to the clinic and they'll have come in and they'll say, oh, he's terribly delusional, he's telling me this, he's telling me that. And I'll say, okay, try this drug. Next time they come back and they go, oh, he's awfully sleepy. I said, what happened to the delusion? Oh, they're all gone. I'm not worried about that anymore. And you go, okay, that was a win. No, we're going to work out the next thing. And you think, oh my goodness, it's like Canute, hold back the tide, keep giving them. So they are there, but we mustn't ignore them. As you've seen, hopefully this morning, there are lots of helpful approaches that we can use. They're not amazing, they're not magic bullet, but I guess if you've heard something this morning that you hadn't known about that you think is relevant to you, then I guess my job has been done here. It's given you a chance to think about what you might do to help yourself. And with that, I'm going to put up this slide, which is my team at the Unity Walk back in 2017, 200 years after James Parkinson published the Shaking Palsy, the essay on the shaking palsy. So we're all in period costume. And I put that slide up to remind me that the reason I can come here today is because there's a whole bunch of really smart, bright young things who are much better than I am, who are back at camp doing all the hard work so that I can come here and try and share with you some of the experience and knowledge that we have.